Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. He started calling me Nurse Goodbody. Security.
Grandma Betty was perfectly fine and happy eating supper.
Do not curse at me. That is inappropriate. I love this story. I'm quite the applesauce mixologist. Let me just say. Whoa. You need morphine? Baby girl, thank you for taking such good care of me. Welcome to the Fresh RN podcast. I am Katie Cleaver.
Hey, Katie. I am Elizabeth Mills.
Thank you guys for listening. Today we're going to talk about dealing with difficult patients, families, and just some plain ridiculousness. So
yeah, it's a good, important topic.
Emphasis on ridiculousness.
See this in your career at some point.
Yeah, it's not like you're going to be immune, I think, to this. Like, there are a lot of ridiculous things that will happen.
Yeah. And you're also dealing with patients and families who have not, this was not in their plan to come to the hospital. So unless, you're, giving birth or something, but you're going to be
sometimes that's not in the plan.
Well,
but
here we go.
It's a whole nother thing. But you think about people though, maybe they weren't planning on being in the hospital, and then all of a sudden they're in the hospital, and maybe they have a dependency on something or coping mechanisms, and they've had this really like awful patient or awful scenario happen. And normally when they get stressed, they smoke, or maybe when they get stressed, they drink or do other things, and they can't do that while they're in the hospital. And then they're sick on top of it. It's just, there's a whole mess of things that could happen. And I wanted to start it off by telling a couple stories of my experience with some difficult patients and families and ridiculousness. So I was working on a floor, and I had a patient that he had, I think he had a very minor surgery, a pacemaker placed. He had a pacemaker placed the day before. And that, I have never had a pacemaker placed. Ever, personally, but I've taken care of a lot of patients that have. And it's not a painful surgery from the many patients I have taken care of. And this guy, I walk into report after report to this guy screaming at the top of his lungs at me to get him morphine now. Like, scream. I've never been spoken. I don't think I had ever been spoken to like that. And literally screaming at me. And I'm like, whoa, you need morphine? Like, what's going on? Like, if you legit need 2 milligrams of IV morphine immediately a day after a pacemaker place, like, there's a problem.
Yes, something's going on.
I need to let the doctor know, right?
Right.
And then I call the cardiologist at 6, or wait, what, that would have been like 7:20 in the morning. Like, hey, so this just happened. And in the moment, I was like, oh, okay, like to the patient, like I didn't know what to do. And I walk out, I call the doctor, and he goes, no. Katie, this guy is a known, abuses cocaine, and we know this. And it's been X amount of time since he's had some. And he's screaming at you because he needs to feel blank.
Needing medication, yeah.
Yes. So I have never seen a patient get discharged so fast. But I also have never been spoken to like that. So that was something I was not prepared to deal with. And then I had another experience where I had a patient who, and I honestly don't remember why this guy was in the hospital, but it was something legit. And it wasn't on the ICU. It was like he was a floor patient, but he needed to be in the hospital. And on the floor I was on, we took vitals every 4 hours. And I was working night shift. And I was like, hey, I'm Katie, and he was really rude to me. Yeah, whatever. Very like, and he had no mental issue, no disability, no medications that were, it was like, this guy was just being a jerk to me. Like, I was just like, hi, I'm Katie. Yeah, whatever. Okay. So I figured out that this guy, like, he didn't, I was like, okay, I'll be back in a little while to take your vital signs. No, you won't. and was really condescending to me. And I was like, okay, so just so you know, routinely the doctor has ordered me to take your vital signs every 4 hours overnight. I do not want you to do that. I was like, okay, I got to explain to you the risks and the reasons, or the risks of not allowing me to do that, and the reasons why I need to do that. And if you don't want me to, you don't want me to, and I'll chart that. But I just need to explain this to you. And then actually, he ended up liking me because I didn't go in and take his vitals. But I had to kind of cover all my bases. But so, like, I did not walk into that shift expecting to be yelled at or, like, spoken to very rudely. But that was just kind of like what happened.
What I think is interesting, and I just recently learned about this, was when you are a patient going into a hospital, you have rights as well as responsibilities.
Oh, dang, y'all hear that? Rights and responsibilities.
And nurses need to be aware of what those rights and responsibilities of patients are. And when you have a patient who's clearly could be very, very sick and have a lot going on, there's a reason why they went to the doctor or went to the emergency room. Something's going on with them. And then all of a sudden they get admitted, and then they have a plethora of stuff that you need to do to take care of them. It's our responsibility to take care. It's our responsibility to take care of them, but it's their responsibility also to
receive the care, I guess?
Receive the care, and somewhat comply with what we're asking of them to do.
Because it's one thing if somebody doesn't want to do something that's part of the treatment plan. I get that. But there's no reason to be a jerk to me.
No.
And no matter what your diagnosis is. I don't care if you have cancer. You can't be a jerk just because you have cancer.
No, or disrespectful,
right.
I guess. I
right.
mean, we know that you didn't plan on coming here, or we know, these patients didn't expect to come into the hospital. You don't have to necessarily be nice to me, but when you start being just blatant disrespect, name calling.
Yeah, had that happen to me before.
Yeah, just being nasty. I'm here to take care of you. I'm here to make sure that you're safe, make sure that your physical needs are met in a sense, and so I'm here to do a job. And you know what? If they're not wanting to comply with what our orders are and our protocols are, then they also have the right to sign out against medical advice.
Absolutely do.
And we try our darndest to not do that because they need to be in the hospital, for a reason. But if they are of sound mind, they can make that decision. So dealing with difficult patients is a challenge. And I don't think, you can deal with it, and then every scenario is different. So it's so easy not to take it personally, or to take it personally. That's what I'm trying to say. I'm somebody who I do take it personally, but I'm trying to work on.
I have in my little talking point. I love talking points. Because it's hard for me. I know what I feel, but it's hard for me to verbalize it. So when I hear someone verbalize something and I'm like, hey, I like the way you said that, I keep it in mind. So I had a patient that I was doing an internship. I wasn't even a registered nurse yet. And I was kind of in this observing kind of thing. And this young kid had broken it. He was in some ATV or motorcycle accident. Excuse me. And he broke his hip. And he was irate about something, his pain medication or something. And I think he also had a TBI, a traumatic brain injury, a small one or some, not a huge issue, but he starts screaming at the nurse and he's screaming at her and she goes, "Stop. You will not speak to me that way. I am here to take care of you and I am here to be here for you, but you will not speak to me that way." And boom, he turned around real fast, was very apologetic. And it was she didn't have to take that. She needed to say something to stop him from being so essentially at that point abusive to her. So I wrote that one down. But I have a couple of talking points that I like to say. I have a few things. So my favorite one is, that is inappropriate.
Yeah.
If you like kind of name
Yeah.
what they're saying, like it is really inappropriate for you to speak to me like that. I've had when like a patient will say something kind of sexually explicit. One time I had a female patient, but it was her husband. He said he started calling me Nurse Goodbody and winking at me. Yeah. Yeah. It's like, so that's inappropriate.
I'm so sorry.
Yeah. Or you will not speak to me like that is a good one. Do not curse at me. And I'm here to help you to be your nurse and not to be disrespected. So maybe use one or a combo of those, but usually it shuts the rudeness or maybe the sexually inexplicit kind of things down. And you usually don't really need to elaborate a whole bunch because it usually snaps them out of their rudeness and typically profusely apologize. We are human beings too and really need to be treated with respect. Like just because I'm your nurse doesn't mean you get to talk to me however you want.
Right.
I find that people when they're sick, even when they're not in the hospital, but loved ones are sick, like they don't act the same, and
Of course not.
it's pretty exaggerated sometimes in the hospital and people act the way that they wouldn't. But there's something that I really want to make sure that you as a new nurse know, and it took me a while to figure this out. That even though someone is ill or going through something really tough, it does not give them an excuse to be rude, demeaning, demanding, or inappropriate to you. You deserve respect. And sometimes when people are being rude, it is an unhealthy way of dealing with their situation. And at that point, you need to command respect from them. There's absolutely no excuse or reason for them to treat you poorly, and you absolutely do not deserve it. Sometimes you need to remind people to treat you respectfully. And typically just that little reminder works. Mm-hmm. But it's really important to do that because sometimes when people are going through something tough, they lash out at those that are helping them. It can be a natural way to deal with something that's totally out of control for them. And while that may be how they're instinctively dealing with something, it doesn't make it okay. And they may need just a little firm but respectful reminder that there are better ways to deal with the situation.
And I think it's okay to say, I understand this is incredibly hard, but I am here to help you. Mm-hmm. And it is hard for me to do my job effectively and well if you're constantly disrespecting me.
Mm-hmm. And I feel like this is kind of like code for, hey, don't treat me like that. It is okay if you are frustrated with everything and you were kind of taking it out on me. And that's okay if that was your instinct, but you need to know that it's not okay to talk to me like that, and we've got to change with how you're dealing with this. I'm still going to take really good care of you, and even though we had this little bump in the road, being sick sucks, and I really get it, and if you want to talk about it, I'm here.
Right.
And that's calling the behavior out and calling it what it is, commanding respect, but also, I'm still going to take really good care of you. I hate that you're sick or whatever's happened to you. Don't treat me like that, and I'm still going to take care of you.
Let's talk a little bit about, when that situation escalates. Because you may see this more with patients, but more with families. And you're, especially in anywhere, we see violence in a lot of places these days. I'm not saying these are violent situations, but if you ever feel, you're there, your number one goal is patient safety, but you have to be working in a safe environment too. So if you ever feel threatened in any way by a patient or family member, hospitals have security and you use them.
Oh my God, I love security.
Security.
I love y'all. You guys are my BFFs.
They are awesome. I worked in a trauma unit this year, and you see patients who've been shot and stabbed and car accidents and all this stuff, and it's really high stress, and you get some of these families who come in really angry, and sometimes they're not afraid to get in your face. Well, let me tell you, don't hesitate to call a security alert or code whatever gray. We use code gray. To get help, because you need to be able to be safe in your job and you need to feel safe. That's actually the facility that you work at. That's one of their responsibilities, is to provide a safe working environment for you. And
Yeah.
they should not hesitate. If someone is blatantly violent or threatening, escort them right off the property, and you can continue on.
Exactly. I think on our ICU, we had a button installed to get security up there quickly, so you don't have to actually waste time on the phone. And I accidentally.
Oh, that button is awesome. Yeah, somebody actually accidentally hit it last week.
So I accidentally hit it like a couple weeks after it was put up, and man, they were running to the unit, and they were a little kind of so mad at me for accidentally hitting it, but I was so appreciative because they were there so fast. And I had, and I've got some patients and some people, they just need to see someone, especially even if they're delirious, ICU delirium, or if they're confused or sundowning, sometimes that person in a uniform is very helpful.
Yeah, security can come help you with patients too. They
Yes.
will. Right.
So I actually have a good example of this. So I had a patient, she was sundowning, and I honestly don't remember why she was in the hospital, but she had a chest tube that was connected to wall suction. So she couldn't get too far, but
She really could have if she wanted to.
I mean, yeah, she really
Wanted
could have. But so she started getting confused, which turned into like combative, which turned into hitting the staff. That was challenging. So she was actually
Define sundowning for some of us.
Oh, yeah.
Would you like to? You want me to?
Literally, when the sun sets, the confusion awakens.
Yes.
I'm not kidding.
Absolutely.
It is like clockwork. As
Literally.
it gets dark, it is, Grandma Betty was perfectly fine and happy eating supper, and the sun has gone down, and it's like
And the family has left.
the family's left.
Full
and
moon time. Yeah.
Oh dear, yes.
It's such an interesting
You see
phenomenon.
it in a lot of dementia and
yeah,
Alzheimer's,
like,
and
yeah.
you can see it in
So
an older population.
And then you add in that typically older population. Then you add in someone who has something acutely wrong with them. They're sick for some reason, and that makes it even worse typically. So this woman was very confused. She thought she was somewhere else. Reagan was the president, and all this. I'm pretty sure she thought she was at home and didn't know why all these people were in her home. And I was like, and she starts.
I would try to go back to when times were good too.
Yeah.
I guess.
So I'm like, I kind of hear yelling, and I'm going down the hall, and I see this tiny little CNA. I'm 6 feet tall. This CNA couldn't have been probably was 5 feet, and very small. Like trying to pull, this lady had gotten out of bed and had stretched her chest tube about as far as it could go and on her feet and stuff. And this CNA is like, no, hurry. Like she didn't, because she was literally about to pull it out. And I walk in the room and I'm like, oh, this is what's happening. I guess I'm going to get this situation under control. And she is, I'm kind of like she doesn't, like I'm not going to body wrap the woman, but I'm like start kind of body bumping her back towards the bed just to get more slack on the chest tube. She's beating on my chest, like screaming. Aww. And I'm, this
Because you feel sorry for them.
You feel sorry, but then you're kind of also getting attacked.
And you're like, yeah.
And it was like, okay, security. Like I know I could technically handle this woman because she's small and whatever, but I think this chick needs to see someone in a uniform. Because that's going to I have a feeling that's going to make her feel secure or make her feel like someone's got control of the situation. So I yell, security, somebody call security. And then, I love my security yet again. They came up real quick. And when she saw someone in a uniform, it was like, oh, thank gosh you're here, man.
Yeah, they're trying to beat me up.
And she, exactly. So she sat in there with them and had a conversation. And
arrest them, officer.
Exactly. That's exactly what happened. And it's like you hate because she was confused. But that was the way to get control of that situation because I continuing to try to, if I even got her back to the bed, it wasn't going to calm her down because I was the big scary person, but if you get the guy in the uniform that's like, hey, I'm here to help. What's going on?
Yes, yeah.
And so you want to try and think about stuff like that because you are going to deal with confusion. If you're working in the ICU, delirium is very legit and people act. I've had patients that were punching and kicking and ripping IVs out, and I come in the next day and they're like, hey, what's your name? Hi, it's nice to meet you. And I'm like, you punched me like 7 times yesterday and I took care of you for 12 hours. No way. Like, that was not me. So delirium and that kind of stuff happens. And I think it's important for us to know when to call security and not to feel like we can only call them when it's awful. I had a patient situation when I was early in my career, again, in a semi-private room, and I was taking care of both patients. And I was in the room with one of them, giving him his meds, and I hear on the other side of the room the patient and his mother screaming at the top of their lungs to each other. And that would have been a call security situation, or go in and intervene and say, guys, I need you to not scream. There's a lot of other people here, because he wanted to kick his mom out. He was 18 years old, and his mom didn't want to leave. And it was like, he's an adult. If he doesn't want you here, and
he has the right.
He absolutely has the right. And I should have gotten control of that situation better and gotten security in, but I wasn't empowered. I didn't feel like that was something I could do. I don't know why. So I want to encourage you guys, if you ever feel unsafe, or if you feel like there's a situation that's going on that you can't really control, which you may get some better control, or not better control, I don't want to say it like that. You may be able to kind of navigate situations a little bit better with more experience, but don't ever feel like you can't call that support staff, because your safety, you being safe is number one,
right?
And number two, you being treated with respect,
yeah,
and command that no matter what's going on with the patient, it doesn't give them a right to kind of like disrespect you or hurt you in any way.
Have you ever been involved in a situation or facility where you felt unsafe or unsecure, where the facility's team has not been able to rectify that situation, and make you ultimately in the end feel secure? And if so, what are the recourses for people in those situations?
So for me, I have never experienced that. At the hospitals and facilities I've been to, security has been amazing.
Yeah.
And I don't know if I've met anyone. And if you have had that experience, I would, honestly, if I was working at a hospital and I had a situation come up and I called security and they did not do something, or I did not feel safe, I'm looking for a new job.
Yeah, right.
So I don't think that's the norm, hopefully. I think a lot of security departments are very protective of their nurses and protective of their staff, is what I've seen. But then again, I have not worked in every hospital, and I don't know.
I mean, in the trauma unit where I worked, we were a locked unit, which was awesome because we had one door in and out for families, and they had to buzz, and we had cameras. And so if we ever had a situation where a patient's safety was compromised, i.e. if they were part of, violence, gang violence, we tried in a lot of cases, actually, we set up like privacy accounts. So if somebody wanted to come and see where they are to retaliate, they couldn't look them up in the hospital.
Yeah.
Which is great. And that's another thing that you kind of evaluate on the admission assessment. But I've always felt like if it's really a hostile environment, public safety is going to get, or patients or security is going to get whatever
support.
They're going to get whatever support, and they're going to get, they're going to get out. I mean, they're going to escort that family member out. Or if it's a patient, we've called the doctor before and said, hey, this is what's going on. Mm-hmm. And, if they're of sound mind, if they want to sign out, we let them go. But if they're confused and there's other things going on, maybe they need some medicine to kind of help settle them down.
Yeah, and we've been in that situation before. We've gotten different medications, or we talk to the family and find out something that's helpful, or get a family member there. Sometimes just having a familiar face is enough.
Right.
But, I have had situations where I had someone she was really rude to me, but I didn't feel unsafe. But she wanted to leave AMA, and she had a pulmonary embolism, and the doctor was like, you're on a heparin drip, and if you leave, you're most likely going to die. And he had to have her verbalize that and fill out paperwork, and she ended up leaving.
And it happens.
It happens, but, you do all you can, but you can't, force these people to stay in the hospital. So, the bottom line is your safety and you being respected.
And going back to dealing with difficult patients and families, let's say in a sense they're not, they're just difficult. They're not for whatever reason, Katie just showed me a picture of her baby. It's so cute.
And she lost all train of thought.
I know, I lose it. But anyway,
She really did lose it.
sometimes
We're off the rails.
we had a lady a while ago who was incredibly sick, and she was one of these patients who came into the hospital for something small, and more problems came about, and she ended up being very, very sick. And her poor husband, you know, he was under stress. He couldn't work, so he wasn't making any money. He was at the hospital every day. She was getting sicker, and he was very difficult to deal with. He was not very nice. And one day I had her one night, and I really just let him talk. I just said, tell me and he honestly, and this doesn't happen every time, but at the end he was like, thanks for listening to me. And, but it, sometimes if they're difficult to deal with, I'll say, well, tell me, what questions do you have about things? Are you unsure about things? Cause sometimes it's like, we haven't seen a doctor in 3 days.
Yeah.
Or, I
have one. I had a patient, I was getting a report, and I got a report that the patient's husband was a jerk. And he was just so mean. And I find out that the patient, if a patient fails a swallow evaluation by the bedside staff, we wait for a speech therapist to come closely evaluate their swallowing. Very common with stroke patients, compromised swallowing. So, of course, his wife came in at a weird time and failed the swallow eval, and then the speech therapist saw him, 12 hours later. And then, it's like, okay, so she's not swallowing safely, but I feel like if we give her a day or two, she'll probably swallow safely. So they didn't want to put a tube feeding down, because that's really traumatizing, especially if we can just wait a day or two. And she was, I'm not 100% sure, but I think the patient was kind of out of it, so she didn't really realize that she wasn't eating, but the husband was really upset about it naturally. And I don't think anyone had really took the time to explain it to him. So I went in there knowing this was the issue. I went in with that kind of like open-ended, what's going on? And he verbalized to me how important that was. So I was able to say, okay, this is the most important thing in the world to this guy. I can take care of, his wife is totally stable. Like, I got her. Like, I don't need to, I can just do my normal thing with her. But this guy needs some help. So he needs to know that someone's gonna look at her. So I was like, okay, so speech therapy doesn't get here till 8:30. I am gonna call and page them as soon as they're here today. And I'm gonna make sure that she gets seen early. And then, so when I paged him, I let him know when I talked to him, and they said, hey, we're going to be there around 10. So I went and let him know. And it was like, he unclenched. Like, he was really rude to the previous staff, but he just kind of unclenched because he knew that his problem was going to be taken care of. And then the speech therapy ended up coming by, and then she ended up doing well and getting on this thickened diet and whatnot. But, he was really crappy to the staff before, but it was because he was really frustrated about a very specific issue.
These issues are completely out of his control.
Right.
He couldn't do anything to help out his wife.
Mm-hmm. Oh, I got one more really good story. Okay. I love this story. So, okay, again, neuro ICU. And I honestly don't remember why this guy was in the hospital. I think he fell and hit his head and had a bleed or something like that. I don't know. He was a very not tall man. He was not a large man, but I think he had some baseline substance abuse issues. I don't know if they were active, like he was actively withdrawing. I don't think that was the issue. But he, the day before, refused to take any medications. Oh, he was, okay, wait, now I remember. The pieces are coming back. He had been, had various substance abuse things, but had a kind of a baseline history of alcoholism. And had been in the hospital for a little while. And, the alcohol withdrawal kicks in after 3 days, and then it kind of tapers down. And he was kind of on the end of it, where he was just kind of getting some, I think it was oral Ativan or something. And I come in and I get report. This guy's belligerent. He's abusive. He is tied with 4-point restraints and a posy vest, and he's not taking any of his meds. And he's mean and wouldn't take any meds yesterday. And he's got a sitter. I'm like, oh, that's not really what you want to hear in report. So I go in. I'm like, all right, this is going to be an interesting day. So I go in, and I pull up a chair. He's calm, but he's friggin' tied down, like everywhere. And I pull up a chair and I sat next to him. I was like, hey man, what's up? My name's Katie. Taking care of you today. He's like, oh, hi. And I was like, can I take these things off your arms? And he was like, yeah, that'd be great. So I left the Posey vest on. But after I did my assessment and kind of was in their room for a little while, I was like, let's just see what he's like without these restraints on. And he was real sassy. But you know how when there are some people that are like, I'm not going to do that. And it's like, yes, you're going to do that. You know, like that kind of sass back and forth. Like that was the way this guy communicated. And I think people thought that was him being non-compliant and really like a jerk. But I don't know about you. I loved it. Like he was like, I'm not going to do it. I remember the way I got him to take his meds. I crushed them all up, put them in some applesauce. I'm quite the applesauce mixologist, let me just say. But I crushed them all up, put them in one bite. And I was like, he's like, I'm not taking my meds. I said, yes, you're going to take your meds. You are going to take these meds. It's going to be one bite. It's going to be no big deal. Here you go. Oh, I don't want to do it. Yes, you are. Here you go. Nah, fine. And he took the big bite. And he took the first time he'd take meds in 2 or 3 days. And we were just being real sassy back and forth. He had a family member come by, and that family member had the same kind of way of communicating, like kind of like gruff, like yelling back and forth at each other. But that was the way that they communicated, and like kind of it was endearing, you know.
Right.
But you had to kind of get to that point to realize it and push back.
Right.
So by the end of the shift, I got rid of the sitter, got rid of all the restraints, and I transferred him out of the ICU. And when I transferred out of the ICU, they had an order for physical therapy, but they hadn't been doing it because he'd been so belligerent. Mm-hmm. And I think it was people were wanting him to do things. You need to do this. And he was saying, no, I'm not going to do that. And then people get really upset when it was like, just kind of need to kind of like go back and forth in like a joking way.
Yeah.
And I had him, I transferred him from the ICU bed to the floor bed because they're different beds, you know? And I was like, we were going to transfer him over. I was like, you can get up and walk over there. And he was like, oh, really? Thanks. Like no one had let him get up out of bed. And he stood up all tall and stuff. And he was like, I'm going to miss you. Thank you. He said, baby girl, thank you for taking such good care of me. And he like gave me a big hug and had like a tear in his eye and stuff. And his family, it was like, oh,
yeah,
this guy, like I will never forget
It's
him.
learning people.
Yeah. And it was like, he's really, really sassy, but I'm going to get real sassy with him back. And, you know, and that was just, I just had to learn him.
Right.
You know,
that's
and
all
kinda,
it takes sometimes.
Sometimes you got to take the, you know, I was like, you got to be careful when you take off restraints and make sure you're safe. And I felt like I had built a little bit of a rapport with him that I could take off the restraints and just kind of see. And then if I saw him kind of scrolling around in the room, I'd walk by and say, what are you doing in there? Hey,
right.
What you doing? Like in a joking way, not in a punitive way. And he like loved it. You know, I told him that this is my favorite one, and then I think that's probably the end of the episode, but I told him that the heart monitor, which frequently beeps, I told him that was a cursing alarm. It'd go off every time he cursed. So I'd know whenever he cussed. And so it'd go off and say, what are you saying in here? Nothing, I'm being good. Like, so sweet.
I think, you know, takeaways from that is one, learning, assessing people. And I think it takes experience to sometimes feel comfortable with people's different behaviors.
Yeah.
But it's so important to sit there and say, you know what, I get it. I know why you're frustrated. And you know what, I can understand why this would anger you. This would anger me too. No, right. Because you know what, sometimes I try to think, well, you know what, if this was my dad and, he hadn't had a swallow evaluation in 3 days and I didn't understand the stroke disease process and all that other stuff, it's like we're starving him, you know? This is, I get it. I do get it. And sometimes it just helps for them to feel like they have somebody on their side.
Absolutely.
So A lot of times getting down, and you know what, if you can't figure out what's going on with the patient, or you feel like you're not getting anywhere with someone who's being difficult to deal with and they have a lot of complaints and a lot of issues, call the nursing supervisor.
Yeah.
Sometimes that nursing supervisor can come up and just kind of be fresh ears, non-biased, whatever, and just listen. And sometimes they can find out stuff that you didn't know. So utilize your resources, but number one, your safety, your patient safety is obviously number one. Your safety is number one. So knowing that, and if someone's hell-bent on being rude and mean and doesn't want the care that they're getting, they have that right to leave. And I kind of get to the point where I'm like, you know what, if you really want to go, go. I mean,
I'm not going to force this
I'm not
on
going to,
you.
right.
So take home stuff. Remember, your safety is the priority. Commanding respect is, and you deserve to be treated with respect. Just because someone has a specific diagnosis, it is not a license to treat you disrespectfully. And I really want to make sure you guys know that. Remember some of those talking points. Hey, this is not appropriate. You will not speak to me this way. Do not curse at me. I'm here to take care of you. And then kind of letting things, figure out what's going on there. And the important thing and the important aspect of that is say what you need to, but don't penalize them the rest of the day. Don't
Right.
shun them the rest of the day. Still
Right.
take really good care of them.
Right.
Really good non-judgmental care. Remember, what is routine for us is not routine for our patients. So like
Right.
the example of the guy with the stroke evaluation or the swallow evaluation,
yeah.
that's so routine to me. Well, duh, of course this makes sense.
Right.
It makes sense to him. He doesn't eat, sleep, breathe healthcare, and I got to remember that and educate some of these seemingly obvious things. So, so remember that. And at the show notes, I've got some links to a couple blog posts that kind of just what we talked about kind of puts it in writing, so you can kind of. I actually had someone tell me they took one of these and when they had a patient on the unit that was particularly abusive, and they printed it out and gave it to each nurse that took care of the patient. So they had some talking points. So I have those links there that you can take a look at some stuff. So I hope this helps. So that will be at freshrn.com/podcast, where you can check out that and check out freshrn.com for more resources, gear, sweatshirts and t-shirts and all that kind of fun stuff. Check us out on social media. And thank you guys so much for listening.
Yes, thank you.
Stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat.